Okay, hi everyone. Welcome to another careers series. We've got Emma Collier today, an ST4 in emergency medicine, just talking about her career and how she got into be where she is now. So take it away, Emma.
Hi, everybody. Thank you for coming along. Now, hopefully at the moment you can see a PowerPoint being shared. I don't fully have your perspective, but I'm just going to stop sharing that for a second, if I can, because I want to just get a little bit of an idea about who is here this evening, and just what backgrounds you are. So if you're medical students, foundation years, then that would be really helpful. If you want to just pop that in the chat for everybody who's here. And if people want to say where they are tuning in from, then that would be very nice as well. So if anybody wants to volunteer in the chats, thank you very much again for coming along. Hopefully you all have some interest in potentially pursuing a career in emergency medicine, which obviously is my chosen specialty. I'm very glad to have you. It's nice to see that we've got a bit of a mixture of people in the group. We've got some F1s, F2s, a couple of people coming from abroad, and very nice to see some people that are coming to or in Scotland as well. As you can maybe be able to tell from my accent, that is from where I'm from originally. Great. Okay, so if you keep popping that in, Frankie is going to stay on the line as well. So if any kind of questions pop up, then she'll be able to highlight them, and also we'll take you through a short presentation, just a little bit about my background, what I think emergency medicine is, and a little bit more focus on the training programme and the applications process as well, which will be a bit of an overview for some of you, maybe kind of in your earlier stages, and potentially some quite useful insights for those of you who are getting towards putting in applications in the near future. I've managed to get some advice from the applications for this year's applicants for ACCS, so hopefully some of those things will be useful for you guys as well. So I'm now going to go on to the PowerPoint presentation. So I won't necessarily be able to see the chat, but Frankie will keep in touch. So, right. So this is what we're going to cover this evening. We're going to talk a little bit about emergency medicine. For some of you, that'll be quite new, and for some of you, you'll kind of have a bit of an idea about what emergency medicine is in the UK, and what it might feel like to be working in an A&E already. And we'll talk to you a little bit about what kind of the job role entails, and also a little bit about the wider career opportunities, the positives and negatives, the reason that we turn up to work every day. And then we'll go over some of the things in terms of the training route and national recruitment, which some of you may be familiar with, but is a bit of a head spin for people trying to get used to it for the first time. And then we'll have plenty of time for questions at the end. I'm sure you don't want to hear me talk for the whole time, so very happy to answer lots of questions. So we'll talk a little bit about who I am first, and what my background is and how I've got to this stage. As Frankie said, I am now ST4 equivalent, not quite ST4 officially yet. I graduated in 2013 from University of Glasgow. And originally I wanted to be an obstetrician. I think it was the classic combination of surgery, dealing with obstetric emergencies that sort of pulled me towards it. Also a little bit of medicine, which as you can sort of see, does translate to A&E. I did my foundation years in Glasgow and was very fortunate to do my first rotation of FY2 in Hare Myers Hospital in A&E, which then made me realise that actually that was what I loved and wanted to go into. So after that time, I put my ambitions for obstetrics on hold and went off to Australia, which was, say, and still is, a very common thing to do. And a great opportunity for those of you that are able to do it. And I worked in an A&E there for about 18 months before coming back and spending a few months locuming and also a bit of travelling. During that time, I obviously applied and got into the ACCS for emergency medicine. I decided to apply for the first 3 years, and I didn't apply for a run-through training programme. And I came down to West Yorkshire for that, which is, for those of you who don't know, that's Leeds area in the north of England. And then after I did my ACCS training, I then stayed in Leeds hospitals as a senior clinical fellow, doing a bit of EM registraring and also undergraduate education. And then I've gone through national recruitment yet again, and I'm officially starting my ST4 in South East Scotland in this coming August. So I think the one thing I always think about is emergency medicine is a little bit like joining a club. I think probably every specialty feels that. And what you might think of as the emergency medicine club is lots of really loud, sporty, adrenaline junkies. But I think there's a bit of a mixture within that, and certainly on the quieter end of the spectrum. I think these are kind of some of the essential things that I think you need to have when you want to pursue a career in emergency medicine, and certainly some of the things that I discovered during my foundation years of things that I really liked to get from work. I enjoyed working with a team. I liked having lots of different people to work with. I enjoyed having regular patient contact. I think you have to be very comfortable with the uncertainty. It's certainly, it's not like a minor ops list where you can be doing the same thing with little variations. You can literally be resuscitating one patient and doing crazy things to sorting out a broken finger, or someone ask you what the rash that appeared on their foot 2 weeks ago is. So it's all very, very variable. And that also applies to the job pattern and the shifts. We obviously do a lot of shift work, and that continues for the whole career in emergency medicine. And I think you need to like that sort of hands-on approach. There is a reason that medical dramas quite often focus on ERs, because it's that sort of classic what the public think a doctor is very much about history, examination, formulating diagnosis, and doing kind of basic tests. And I think some of the sort of impression that people get from the outside is of emergency medicine being, you know, the emergency medics are potentially quite loud and outspoken. I haven't found that that people are particularly bullish or mean, but they will advocate for their patient and for their team, and can sometimes be quite outspoken about that. So some of you may have already experienced life as an SHO in emergency medicine. The shifts tend to be focused predominantly on evening and night shifts, just given that that's when a lot of our load of work happens, but you will have some days spaced out throughout that. So teaching in non-clinical time is often worked in. It's not always the most flexible of rotas because we do need to have a lot of coverage for our out of hours work. And you will find that typically the shifts will be maybe shorter than some other specialties, kind of 8 to 10 hour shift patterns. At the moment, I work 9-hour shifts maximum, including my night shifts, which can be very busy, but does take the pressure off. If you can imagine, a very intense shift lasting 12 hours doesn't put anyone in the best of moods. So sticking to shorter shifts for A&E is generally what people do, and I think that kind of reflects across the country now. I think for registrars, they generally say it's a better rota pattern. My current job self-rosters, which means it's very, very flexible. But that again will vary depending on where you work across the country. Consultants, which may seem like a far place away, are increasingly working night shifts. At the hospital I work at is a major trauma centre and requires a consultant to do their night shifts there, and I think that's probably more common practice than it was, say, 5-10 years ago, having the new consultant contracts involving night shifts. But their night shifts are proportionally worth a lot more, so they may work 2 night shifts in a week, and then have the rest of the week off or do some non-clinical time. So generally the consultants find that their balance of shifts works out quite well, but again can vary from hospital to hospital. We obviously work across a whole department, which is contained, so it's very different to different specialties, where you might work somewhere one day and another place another, but we do obviously have very different work demands depending on where in the department you're working. So we've got obviously the resus area, majors, ambulatory. Sometimes you'll have a minor injuries unit, although that might be separate from the emergency department. Some hospitals will have clinical decisions units as well, so they might have short stay 24-hour inpatients, or places where people come for routine investigations, such as things like DVT investigations during the day, that have certain protocols. We certainly lost our CDU capacity during the changes with COVID, but it was part of the department that I worked in. Okay, so I guess that's how we work. I guess want to have a little think about what we do and what is emergency medicine. And emergency medicine is a fairly new specialty. It's only been around for the Royal College of Emergency Medicine, just celebrated its 50th anniversary a couple of years ago. I should probably know that. But so it's a fairly new specialty, and I think what I can say about it is that we are generalists. We're also resuscitation experts, and we, in terms of the medicine, we have such varied presentations, and we deal with multi-system trauma, isolated traumas, medical emergencies, cardiac emergencies, major illness, and also a whole host of minor illness, mental health, social care. As you can probably tell just from vague mentions in the news, the A&E is a melting pot of kind of what's happening in the kind of general population politically and economically. So we see a lot of impact from other areas, as it's a kind of first stop for everybody. But I think being a generalist is kind of something that I was very much drawn to. Talking about being an obstetrician, I like the medical, the surgical being all mixed together, and that's kind of how I got into emergency medicine. And certainly compared to obstetrics, I think I have much cleaner and drier shoes, as we're quite good at getting out the way of the puddles of blood that come towards us. But you have to realise that you are a generalist and you're a specialist of very limited things. So you're relying on working with specialists as an emergency medic. And actually that comes down to what the skills of an emergency medic are, in that really is about teamwork, leadership, communication, diagnostic. It's much more about the management and the running of facilitating that that patient's pathway through the hospital, as much as it is about the medicine. And that's something that you sort of start to develop in your later years, once you've built up a bit more experience with the medicine. And really, some people might see the A&E department and emergency medicine as an extended triage. And in some ways, they're not wrong. You always used to joke when you're a junior that it would either be discharge, admit to medicine, admit to surgery, or they're so unwell that they go to ICU. It does sometimes, some days, feel very much like that. That you're sort of sifting through patients and getting them to the right bit, but there's a lot of satisfaction in that as well, and I think in developing good working relationships with your colleagues. And of course there is the gory bits as well. You get good at putting in all sorts of lines, drains, intubation, sedation, manipulation. There's generally some blood somewhere, hopefully not on you, and you can get lots of problem solving work as well, just trying to figure out what you're going to do with somebody. People come in with all sorts of things attached to them. I certainly remember a case where I had to figure out what I was going to do about a guy with a nail through his finger, except from the nail was also attached to a plank of wood. So there's lots of little things you can use your clinical experience to figure out what you're going to do about the reality in front of you. So I think one of the good things about emergency medicine is that there are lots of opportunities. I have clearly taken some of those opportunities as working as a clinical fellow, and I know lots of my friends and colleagues have done the same. So I've just popped down a few different types of clinical fellow jobs that I can think of, that I've heard of, or things that people do. So obviously education is quite a big, quite popular with emergency medics. Some people like to do quality improvement, definitely not me. But also the more clinical things like trauma, ultrasound. There are clinical fellows in musculoskeletal medicine, sports medicine. There is always that person that's gone off to Antarctica or done other fun expedition type medicine, because these are the skills that you get, and they really do lend themselves to quite independent work, and potentially in quite remote areas. And there's lots of pre-hospital crowd medicine and other areas that you can develop interest. I think because you are a generalist, you've got lots of options open to you. And there's some official training pathways that can be taken after getting into your initial training pathway, and that would be things like dual training with intensive care, pediatrics, and pre-hospital medicine. So they're the kind of other training pathways that you can take in conjunction with emergency medicine. The pediatrics, obviously, pediatric emergency medicine, which I haven't put down there, and some people will exclusively work as pediatric EM consultants, and they can come from pediatric backgrounds, or they can come through the EM route as well. So let me just take a wee drink. Hopefully I haven't bored you to tears yet. I'm going to just mention what's in this little box here, in that there are in other specialties opportunities to take out of program experiences. So you can either do that out of program experience, which is out of training, or you can do that as an out of program experience for training. And you can depending on the deanery, you can do that at any point. So people will use that to do their clinical fellows, but they might use it for something a little bit more exciting as well. I certainly know people that have gone down and joined HEMS for 6 months to a year. People might use it to do expedition medicine, and I have a friend who's just come back from working in New Zealand for the last 18 months whilst still maintaining his training number in Leeds. So I think really your imagination is the limit on that one, and also what the deanery will approve, which is definitely variable, but I think people are quite keen to let people have other experiences and realise that that's something that enriches them as a clinician rather than detracts from their training, which is not quite such a common thought in some of the other specialties. In the same way, less than full-time training is very much an achievable goal in emergency medicine, and the Royal College certainly was kind of one of the forerunners of trying to implement less than full-time training, partly because they kept losing so many registrars from the specialty, and I think that's been a big boost really in terms of retention, and certainly something that I'll be considering over the next few years, without having any kind of particular reason other than I don't want to work quite so much, which is fine. And I think when you talk about portfolio careers, they're obviously very popular, and general practice is something that's seen as a good route into having a portfolio career. But I would say that emergency medicine, although it's a longer training pathway, is also great as well. But there's lots of positives. There's lots of negatives as well. And for those of you that are already working, you know that it's not all easy. And emergency medicine gets a lot of bad press, really, doesn't it? I think on a more personal level, there is a lot of out of hours work. You have to work around your weekends, evenings and nights, and that's a lifelong prospect. Also from a clinical perspective, you're making some really high risk decisions, deciding when to send people home, deciding when to do a CT scan or not do a CT scan. Can you work out from your clinical decision making that someone doesn't have an aortic dissection, you send them home, they might die, which really does take its toll, and there's ways of working around that, but you're only human, and we do miss things, and that's kind of the nature of the game. And it's the constant decision making as well. You are very much interrupted, kind of every few minutes. Sometimes there will be decisions made on, does this patient get seen over this patient? You will be constantly being asked to review blood gases, ECGs. When you get a bit more senior, you'll be interrupted from your own patients because the juniors need to ask advice about theirs. So it is just, you're constantly making decisions. You make, I don't even know how many decisions within the space of an hour, which is one of the reasons that the shift pattern tends to be quite short, is because they recognise that your brain can only cope with so much before it becomes overloaded. And certainly it's a very noisy environment. I think if that's something you find particularly stimulating, then potentially emergency medicine is not for you. It's noisy, it's smelly, and certainly I know that sometimes I come home and I can still hear the monitors dinging in my head as I'm falling asleep. Because you learn to cut it out when you're at work, but it is still something that you notice. And it's sometimes a specialty where you are seeing the very worst of patients and the public. There will be violent and aggressive patients, not necessarily because they are trying to be. Sometimes, obviously, we do have people who are quite psychiatrically disturbed or demented, but you will also have people who are potentially carrying weapons, who are in police custody, who are just generally quite angry because they've been waiting for 8 hours and they haven't been seen by a patient yet, and they don't quite appreciate that you've been potentially dealing with some quite heavy emotional things on the other side. So sometimes that sort of conflict between what you're doing and what the public's expectations can make people quite angry. And there's obviously a lot of sadness that we see as well. And we do learn to sort of separate ourselves from that, but that in itself has its own kind of impact. So it certainly is a bit of an emotional roller coaster from time to time. But for me, it does tend to balance itself out with a lot of the satisfying interactions I get with patients and with my colleagues. So I was trying to have a little think about why actually, after looking at the negatives, why you might want to be an emergency medic. And I think one of the things that I've always thought is you've got such a privileged position as the first clinician to see a patient as they're coming into the hospital. You can really make a difference by explaining things to them and giving them time and understanding. And it is a really privileged place to be. You see a lot of people sometimes potentially on the worst day, and you get to try and do that well. Because I think you've got that feeling that you've done the best that you can. You've not caused them to be unwell. You're just trying to figure out what's going on and give them the best. One of the things that I found contrasted to that was when I was doing my anesthetics, was that I was giving them the drugs that could make them really unwell, and that didn't quite sit as well with me after coming from a kind of emergency background, way of feeling that you're doing the best to try and help someone get something fixed. So I think you can really get a lot of satisfaction with your interactions with patients in emergency medicine. But I'm also completely okay with not having extensive continuity of care. And I think that's one of the aspects of things for me that I like about emergency medicine and I didn't find worked for me with other specialties, that I didn't feel like I wanted to do clinics, and I didn't necessarily want to be the doctor that's looking after them, because that has its own responsibilities in terms of your own free time as well. And you probably will have seen that with people who are specialist physicians and surgeons having patients that will be able to phone them up at all hours, which is great if that's the type of person you are, but certainly wasn't for me. And I think because it is a skills-based specialty as well, you get lots of satisfaction out of doing kind of nice practical skills and doing them well. And I think I've already mentioned about how you get to be quite creative, and I like working in the team. I work with some really great people, and sometimes those people are quite funny, And sometimes the patients themselves, as you can imagine, are quite entertaining. And I think for me, just seeing the laughs in life is quite important, and I think emergency medicine fosters that. So for some of you, this is what you'll have been waiting for, is a little bit about how to get into emergency medicine. This might be familiar to some of you. It is not new information. It's certainly very easy to find, but essentially emergency medicine is a 6-year training program after your foundation years, and you can apply to that at 3 different levels. The most common level, I think I would say now, is after your foundation years plus or minus an F3 or 4, applying in at ST1, which is for your ACCS first 3 years, and then continuing as a run-through trainee into ST4 to ST6. But you can also apply in at ST3 if you're eligible, and that's usually people who are maybe trained internationally, or from if you've done something like core surgical program, you can also change over via national recruitment into emergency medicine. And it might be worthwhile pointing out that there is no such thing as switching for ACCS. You have to apply to your college. So in this case, the Royal College of Emergency Medicine, but there are interchangeable skills that you gain, and there are other ways to switch, but it's not as, you don't just get to choose. You have to choose from the start. And you can do what I did and apply in at ST4 after having the competencies of ACCS. I did ACCS, but you can also apply in as an international student with from other backgrounds as well, as long as you meet the criteria. So yeah, this is just a bit more of a breakdown, and certainly if there's any questions on ACCS at the end, then please feel free to ask them, but I'll try and just explain, because I think this is sometimes this is an assumption, is that ACCS is the same, and then you get to choose your specialty after ACCS, which is certainly not the case. You do have to reapply into the specialty of choice if you wanted to change, but the first 2 years are essentially the same. You do 6 months of A&E, 6 months of acute medicine, 6 months of anaesthetics, and 6 months of ICU. For A&E, you're ST3, or sort of pre-reg, baby reg, sometimes treated as full reg kind of year, depending on where you are, will be 12 months in A&E, with you expected to complete competencies in paediatrics and trauma. I do know people that have started off in A&E and then gone into anaesthetics, but they've usually taken non-training pathways to gain the skills to then apply to their higher specialty training in anaesthetics. And then essentially from ST3 onwards, you're doing pure A&E with kind of rotations, usually every 12 months, but depending on which area you work in, might be as little as every 6 months. It's never any shorter than this, as far as I'm aware. And if you wanted to do training in paediatric emergency medicine, pre-hospital, or dual training with ICU, then that obviously takes some additional training years into account. Okay, so sorry, this is already something that you're aware of, but national recruitment for emergency medicine is is essentially national. It's an annual thing. It's central recruitment for posts in England, Wales and Scotland. And I've just included the little snapshot from where the ST4 vacancies were for this year, for the 2022 start dates, just to give you a bit of an idea of what deaneries there are across the UK. And it might be worthwhile pointing out that Scotland is, although counted as one deanery, during the application process, it does get broken down into southeast, west, east and north. So there's 4 areas. So if you get into Scotland, you don't necessarily just get thrown about wherever. Is much more selective than that, but they get lumped together in the numbers as a deanery. So it's an online application, which is submitted through a website called Oriel, and this usually happens around about November. The ACCS recruitment now requires the MRSA exam, which contributes to 40% of your score, and then that's followed up by an interview. And I believe that they interview most eligible applicants, rather than using the MRSA as a screening tool. Obviously, you can see that the interview is quite a big percentage of your score, and then generally offered a job round about March time, and you can decide to accept a post with upgrades as well. So potentially, if somebody doesn't want their post, then you'll get upgraded in your rankings. So, having gone through national recruitment in the last year, this was, and having applied to ACCS previously, this was kind of what I thought the main areas that you need to be looking at in your application. And I think these are the things that you need to be trying to get something for everything, apart from maybe exams. So I think one essential thing is experience of emergency medicine and understanding what a career in emergency medicine is and what it entails. And you can do that through trying to have a placement and do kind of various work experience in that taster weeks, if you don't get a job in it. And you don't necessarily have to have worked in emergency medicine to get a training post, as long as you find other ways to demonstrate that you understand what the specialty means. Something that they always ask, and I hate, it's just not for me, is audit or QI projects. So this is kind of something to look at fairly early, particularly if you do some audits that are related to emergency medicine. That certainly ties in with trying to get some kind of demonstrate experience and understanding. But it doesn't necessarily have to be. If you've followed through an audit cycle, or if you've had an ongoing big quick project, then the skills are still there. And I think it's really about trying to develop those. And obviously things doing like courses relevant to EM. Like everyone tries to get into an ATLS one because it gets points in the application, but there are lots of other courses that you can sort of demonstrate that you are interested in, and that you want to get a training post. Teaching or kind of being involved in education, I think it's quite important as well. And other things like demonstrating teamwork and leadership. It is something that they'll want to see evidence of. I think for applying to emergency medicine, exams are less important, and I wouldn't worry about them too much if you are, say, applying from your FY2. You've got time to do them during your training programme. If you've got a little bit more time and you've got an easygoing F3, F4 year and you want to sit the MR Chem primary exam, then that's great, but I think that's an added bonus rather than an essential. And I would like to say I came up with this before getting hold of what the categories were from this year's ACCS training programme. So this was from someone who's just obtained a post in ACCS emergency medicine starting in August, and this is what they got asked on their electronic application. These were the headings, and I think that kind of fits with what I was saying in terms of audit and research, teaching. They want to know that you understand what is to be working in emergency medicine, and they also want to know why. So you need to sell yourself and say why you would be good at it. It's kind of like the UCAS personal statement for those of you that had to do that. You've got to really sell what you've done and why you'll be a good EM clinician. And that also includes achievements outside of medicine, because I think that's valued within emergency medicine as kind of showing potential leadership qualities. And then, of course, the training courses such as life support courses like ATLS. So if you're successful, then in your application you will get an interview. And from what I gather, most people asked all the same questions, more or less, last year. And these are the questions. So I will let you have a little look at those for those of you who are interested. I suspect that the future years of interviews will be fairly similar, and it's certainly quite reflective of kind of things that I was asked in an interview. The last couple of years, interviews have been done on Microsoft Teams, so they've done away with some of the stations that were part of the face-to-face interviews when I was applying, but certainly some of these questions were quite reflective of what I was asked at the time as well. So they won't change very much. So a couple of things I would think about for application is you have to read the person specification. For ACCS emergency medicine, there's an essential and a desirable criteria for applicants. And if we go back to what was asked for the electronic portfolio, there is mention that the skills and attributes, those should map up to the person specifications. I would have a little look at the Royal College of Emergency Medicine website, which will tell you a little bit more about specialty training and exams. And obviously you're going to get asked about issues relating to emergency medicine, so it's a good idea to keep an eye out for what the current issues are. This interview book is the one that everyone has and recommends, and certainly for the type of questions you'd be asked for an ACCS application, I think it is quite good in terms of learning how to structure your answers. And I think it's really important to find out to really say why you want to do it, because that's really the kind of slant of the questions. And also to have a little think about if you're thinking of applying. There are certainly, for emergency medicine, no real harm in delaying your application. So if you do want to take some time out, F3s, F4s, F5s, then it's not really going to harm your application. So have a little think about when you want to do that as well. So just to end on a little thing. Apparently, we are emergency medics are Jon Snow. Think because we know nothing. But on that note, I will try and answer some questions for you, if you have any. So I'm going to come back and
Much, Emma. That was really interesting and really informative, actually. Um, we haven't had any questions pop up just yet. Guys, make sure you pop them in the chat box and I can ask any because we've still got another sort of 15 minutes spare. But I might just ask you a couple additional questions now, if that's all right, if no one else is asking.
yeah,
Uh,
sure.
so, I mean, you've covered quite a lot of these briefly anyway, but maybe go into a little bit more detail on a couple of them. So, I mean, just following on from the portfolio conversation, what was it that you did for your portfolio? Is there anything in specific you would recommend for medical students or, F1s to look out for, like opportunities to gain easy points and things like that?
I think I was very lucky in that I'd had the opportunity to work as an FY2 in an A&E. I would say that, and I then worked in Australia after that. I don't think I had anything particularly exciting, other than I did kind of qualification in Australia, run by the Australian College of Emergency Medicine, which was a kind of sort of entry level, sort of basic interest thing, not like not quite close to diploma, but something along those lines. But most of my quality improvement projects and things were all kind of related to, because I've wanted to do a career in obstetrics, so things like that. So I'm not sure there was anything. I didn't do ATLS either,
Okay.
before applying. So I wouldn't say I did anything particularly spectacular.
Well, pretty cool that you went to Australia, to be honest. But
Yeah, I
was that
think just for me it was time. But if you're kind of keener to get through quicker, then you might need more of the definite things.
yeah? So I know with other specialties, you're almost penalised if you've worked for too long in that specialty. Is that the same for A&E?
No, I
Okay.
don't. There's not as far as I'm aware, there's not a limit to experience. So
Okay.
for most specialties, it's 18 months that you
Yeah.
can't exceed before you become too qualified to be an ST1.
Yeah.
Um,
Yeah.
but generally, I think it's all experience is good experience for A&E.
Okay. We've got some questions popping up now. So we've got one that says, I have health issues and I'm an ambulatory wheelchair user. I mostly use a stick. I coped with an FY1 in EM, but worry how I would manage as I become a senior. Is EM still a possibility?
I think that's a difficult question to answer. I I mean, and certainly as an able-bodied clinician, it's difficult for me to get a full perspective, but it certainly is a very physical job, and a lot of emergency departments are not well designed for wheelchair users. And I have worked with colleagues with a wheelchair user in anaesthetics, who did have to be quite confident in what he wanted and what he needed, but was certainly capable of performing emergency procedures and intubations. We do have a consultant who is a part wheelchair user, currently working in emergency departments. Um, but she was already qualified before she required to use a wheelchair. So she'd already done all the training. And she can't do a lot of the out of hours work. So I think it might be quite challenging to gain the experience to get to consultancy without having done a lot of the physical skills, if that's something you would be limited by. So I don't know for sure, but that's just what I've seen in the workplace.
Okay. Yeah. A little bit of a difficult one to answer. But it's good that you've
Probably
kind
some,
of had a good
probably
experience.
something to discuss and get a bit of a wider range of kind of feeling for how possible that might be.
Yeah, definitely. We've also got another one saying, I also currently can't work nights. Would reasonable adjustments cover me, or are nights an absolute requirement for training?
I don't know for sure from a kind of point of view, but I wouldn't say that they have to be. Nights are certainly a good opportunity to be on your own and take more responsibility, but you can still get the same amount of experience from working days and evenings, I would say.
Yeah. And then we've got, how do you build confidence for more serious situations? I feel worried about the increasing responsibility as a registrar and consultant, but happy to be an SHO, but do want to progress.
Um, it definitely comes with time. Um, in terms of and it for me I feel like I've got to a certain level but I still have progress and I think even for consultants there'll be certain situations where they will question themselves and their decision making and you it really is kind of engaging yourself in training and kind of wondering kind of reflecting on experience that you have and rehearsing kind of decisions and why you would do and reasoning with yourself for me anyway and you progress with as long as you put yourself in the situations you progress without even really realizing. If I look back to a couple of years ago, like people coming up to me and asking me questions about what to do about a patient was just such an alien experience, and now a few years on I'll just be like, yep, okay, cool, what do you want to ask me, and throw myself into completely different situations, and much more confident with managing cardiac arrests and being the team leader making the decisions. And I think that just comes with time and experience, in a lot of ways, and hopefully having some supportive colleagues.
Okay. We've got a couple of, apparently you might see someone in A&E come August.
Hopefully I will, Jen. I'm at St John's, and if you're there, that's where I'll be.
And I think there's someone concerned about not getting experience in major trauma or resus. Would love to gain skills and portfolio points in expedition medicine, just very doubtful of how I'll do it and intimidated.
Oh, yeah, it's really difficult as an FY2, isn't it, to get experience in trauma and resus because us annoying registrars push everyone out the way, and then the consultants push us out the way. So it's, I mean, I think as an FY2, um, you're still at the start really of a career, and you've got lots of good experience behind you already. But I think, and there's lots of routes into expedition medicine. I would say A&E and GP are probably the kind of two training programs that are probably best suited for that. But there's lots of other courses and things you can do, looking at expedition medicine. If there's what was it? There is some expedition medicine conference I've definitely been to at some point, which is quite useful, probably lots of resources. And I think expedition medicine is really variable as well. So there's there's being a ship's doctor, that's an expedition, to there's going into the cross like going to the south, trekking across the South Pole and being the doctor for that. So it's actually much more about the decision making than trying to deal with lots of major trauma, I think, a lot of the time. So you probably do have a lot of the skills already, but so don't doubt yourself, and if that's what you want to do, go for it.
That's really interesting, actually, because I don't know much about expedition medicine. I don't think I've even heard of that as a specialty before.
It's not really a specialty, but it's certainly something that people do a lot.
Okay.
Yeah,
Yeah, it sounds
you
like
can
an
become an
interesting.
expert in it, but it's not like a I'm a consultant in expedition medicine.
Cool. Can you get any extra points for working in ER during your studies? I've been working the weekends as a doctor assistant in Poland during my 6th year.
I'm not sure if points is the right way to put it, but it's definitely a good thing to sell in terms of your experience and your understanding. So it's coming back to those skills and attributes that you show. If you can demonstrate that from doing extra work, then that all applies. I worked in a bar when I was at medical school, which I actually think set me up quite well for emergency medicine. So I think that was definitely my application somewhere.
Because I mean, even if it's not points, it will definitely still show commitment to the specialty, and that you've been thinking
Yeah, definitely.
things like that.
Mm-hmm.
I've heard a lot about GPs with special interests in emergency medicine. How easy is it realistically to do this?
I think quite. I don't know all about the ins and outs of it, but I would say it is quite easy to do. We do have GPs that are based in A&E, but that's essentially working as a GP in A&E. But we also have, particularly in smaller hospitals, GPs who also do A&E shifts, and they tend to come in as A&E locums. Although sometimes have a more formal arrangement with the hospital, and will work as either SHO or registrar level, depending on their experience. And generally, that's just through working as an A&E SHO and through doing GP training, as far as I'm aware.
Okay, so you almost start. So you do A&E in F2, and then you do GP training, and you can do it via that route.
Yeah, so if you have enough A&E experience, then you can come and essentially locum in A&E. So whether
Okay,
that's working as an FY2 or being a GP trainee,
I see what you
which
mean.
will generally have A&E in its rotation. And it's really just through establishing links with local departments.
Do people
Because
tend to sort of split it half and half, or is it more GP, more A&E, or?
I think it's really personal preference because I think formally it's more on a locum basis. So it's
Okay.
people who might say locum in, um, or maybe have a couple of sessions as a GP and then locum in A&E. But it's less of a
Okay.
formal pathway, but it's very, very possible to do. Yeah,
Well,
aviation medicine is special. Don't really know what they
I'm
do,
just
but
popping the feedback. Oh, sorry, I think there's lag. I don't mean to be interrupting. um, so I've just popped the feedback link on for you guys. If you fill that out, you'll get a certificate of attendance, and keep all these, and it will show commitment to the specialty later down the line. If there's not any questions, I think we've pretty much reached the end of the talk. Yeah, thank you so much, Emma. That was really interesting and informative, and hopefully everyone's got a bit more of a better idea about how to tackle all of this now. Um, and we'll sign off there.
yeah. Well, good luck to everybody in the future. Thanks for coming.
Thanks everyone for coming.